can you put your name and your title and organisation in the chat, and let us know what you'd like to get out from this lunch and learn, and we'll try and make sure that we cover some of those points coming through. Thank you. So Craig, if you can keep an eye as well on the chat and the key points, and then we can pick that up as well.
Absolutely.
In the panel discussion. Thank you so much. Okay, hopefully folk are just starting to add their name, their organisation, and what they want to get out of the lunch and learn. So we'll just give that a minute, and just as I do, it's welcome to Tuesdays, our second Clinical Audit Awareness Week lunch and learn. So looking at patient advocate, really delighted to welcome you all to this lunch and learn, and we'll try and pick up the points that you do put in the chat as much as we possibly can. We'll scoop those up at the end as well, because I think these points will be really important. We've got about 83 people with us, which is lovely. It's not about the number, it's about the quality of the discussion that we have. So delighted to be joined today by Craig Short, who is facilitating our networking session for us. Also Kim Rizal, Head of Patient Engagement at HQIP, and some of the HQIP Sun, so that's the Service User Network members, so Carol Munt and Adrian Hardy. So thank you very much indeed. Just before we start, I just want to make an announcement, which I've got on the screen as well, but I will read out. So this is on behalf of HQIP and NQICAN and the judging panel. Whilst we received some great entries for the patient advocate category, when our judging panel reviewed them against the published criteria, they felt that the entries hadn't fully met the requirements set out. It's recognised that moving forward, it will be helpful to rethink how we title this award category and the criteria used, as we're sure there are great examples of engaging people, communities, patients and carers in clinical audit and QI, so quality improvement out there. So really it is a recognition of, we will review what's happened with this award criteria. We're going to use this lunch and learn. It's really important we use this lunch and learn as a springboard, an opportunity to raise awareness and explore approaches as how the local audit community, clinical audit community, can arrange or improve how they engage with their patient and carer communities. Okay. So, as I've said, delighted to be joined by Kim, Adrian, Carol, and supported by Craig Short, all amazing folk working within the clinical audit community. And for those of you that don't know me, my name's Sarah Chesel, and I'm the General Secretary for NQICAN, so the Deputy Chair, and I'm the lead for the Dorset ICS Innovation Hub. Thank you. The agenda today is we're going to do some basic introductions to NQICAN, and then we're going to explore what patient advocate means from a clinical audit perspective, and we'll give you an opportunity to ask questions as part of our panel discussion coming through, and then we'll talk about the other lunch and learns that we have as well. So NQICAN, National Quality Improvement and Clinical Audit Network, and we are celebrating Clinical Audit Awareness Week 2022, and we do that in collaboration with HQIP, so Healthcare Quality Improvement Partnership, and delighted to be doing so. It's not about focusing just on clinical audit in this one week, it's about what we're doing every day of our working lives. It's about trying to get high quality care for all, putting patients and service users first, and ultimately making a difference, helping patients when they need it most, making sure we've got that high quality care, providing health and well-being in our local communities and all that are in it as well. So behind our purpose, so NQICAN's purpose is multi-factorial, and we must consider all the elements of how we can use clinical audit as that quality improvement tool to make a difference to the quality of patient care. And you'll see that theme running through our lunch and learn today, but also throughout the remainder of the week. To get it right, we need to be striving day in and day out. And we recognise as NQICAN, as HQIP, that we're in a period of change. We are in a period of recovery post a pandemic. We're in recovery from elective surgery. We're in recovery trying to work in an environment which isn't normal, but yet it is our new norm. So within that, we must still strive to make sure we've got high quality care for our patients, for our service users. So through NQICAN, we are doing that in collaboration. Also, there's a platform to share. So this week provides us with an opportunity to share, to network and celebrate what we achieve through clinical audit every day and learn together so that we can do that on a wider scale. We can make a greater impact and we really can make a difference. So what we're looking at is how we can shine a light on clinical audit and the impact it's making to improve patient care and services. And actually we do that together as a team. We are stronger together doing that. So thank you. NQICAN is made up of 12 regional networks that you can see on this map here. And NQICAN have quarterly meetings. So this morning we've had our celebratory meeting, updating from all the regional networks that were able to be present today. But if you're not a member of our network, if you've come because you're interested, because you're involved in clinical audit or improving the quality of care for patients, please do contact us and get involved. So look at where your local regional network is and contact us. And Becca, if you can put the NQICAN email address in the chat, please contact us and we'll put you in touch with your regional chair. We have an NQICAN common purpose and a forward plan, and our regional networks are actively involved in supporting us with this, taking forward and being a voice of NQICAN within your individual region. So do get involved because together we can make a difference. And those networks include NHS Improvement, NHS England, Healthcare Quality Improvement Partnership, NICE, the GIRFT programme, Model Health System, the Royal Colleges, and of course the national clinical audit providers. So please do get involved. It would be fabulous to have you as part of our network. Thank you. Craig, I'm not able to keep up to speed with the chat, but is there anything you feel I need to pick up on just before we look at the Mentimeter?
Yeah. So somebody, I know we covered it at the start, but someone has just asked around will the recordings be available afterwards? So I'll pick that up. So yes, they will be. They'll be shared on our YouTube, so on the NQICAN and HQIP YouTube channels afterwards.
Brilliant. Thank you, Craig. So recognising that we haven't made an award for patient advocate, what we're going to do is use our time exploring what patient advocacy means in clinical audit. So we'd like you just to pop to Mentimeter. So Becca's going to put the details in the chat for you now, which will include the code, and then Becca's going to share the screen. But we would like you to think about what would effectively engaging patients in clinical audit look like to you? And I recognise with the different health and care organisations that we have here, there are going to be some different perspectives coming through, all are incredibly valid. And this is a safe space where we can discuss and explore what you think effectively engaging patients in clinical audit would look like to you. So thank you. We'll just give a couple of minutes.
The Mentimeter come up okay?
Yep, Mentimeter's up. Thank you, Becca. Just waiting. So the code's there on the top of the screen, 19297270.
Hello, it's Adrian. Can you hear me now?
We can, Adrian. Thank you. We're just doing the Mentimeter.
Yes,
no,
it's fine. It's okay. That's life in it with Teams.
That's
I've had to restart my computer so the actual microphone works.
Oh, bless you. Okay, no, really glad to say we can hear you and thank you. There's some really important points coming through. Patients and publics determining what standards are important to them. Okay. empowering patients who are able to suggest clinical audit, be involved with results and help drive improvements forwards. They feel integrated, or an integrated part of the clinical audit process. Using patient feedback and as part of clinical audit data is important, coming from that different angle. Local observations, surveys to involve them in the stages of the clinical audit journey or the patient journey, and sharing those and quality improvements and outcomes that come from them, so they can see we do listen and act on what they have to say. Absolutely powerful point there, and thank you to whoever put that. Really, really powerful. Okay, we've still got results coming in. I think Craig, we'll just give it one more minute if you're in agreement. Thank you, getting the nod from Craig. We've struggled with involving patients in audit, so would welcome ideas. Well, welcome to our Lunch and Learn. We are going to be exploring ideas and looking really at, you know, how we could do this, but also look at how we can make it an achievable part of our programme. Someone's saying true, not tokenistic involvement through the whole process. Really important. All QI in a healthcare setting should focus on patient experience and outcome. So all quality improvement. If the person who put that in, can you just say in the chat? So when you say all QI, I talk about the quality thread. So I'm thinking, you know, we're talking research, we're talking innovation, we're talking clinical audit, we're talking across that quality thread. So if you're in agreement, please do put in the chat just so that I'm aware, or clarify what you mean, please. Thank you. Thank you. So patients suggesting areas of clinical or clinical audit, and the results linked into what matters to patients coming through. Okay, I can see some nods from Adrian who's on my screen, and that's lovely to see nods. Thank you. Okay, let's just pause on that. So Becca, if you stop sharing, I'm really hopeful my slides will remain up on the screen. So Vicky or Craig, are you seeing the slides? What are you saying?
No, they've gone.
At the moment.
Bear with me just 1 second as I just reload. Don't you love PowerPoint Live? It should just be loading. Your screen should just be going black, and it should just be coming. I just need to go to the right slide. Brilliant. Yep. Thank you for the thumbs up. Was that you, Craig? Thank you so much. Okay, so thank you. Some really important points coming through with regards to what you feel effectively engaging patients in clinical audit is. So one of the first things we need to look at is acknowledging that our focus really is on clinical audit, but that there's a wider patient and public engagement. And that was why I was asking the question about who put that up in the Mentimeter. So we must remember that we are looking at the whole quality arena. Our focus is clinical audit today, but we are looking at the wider research, innovation coming through, clinical audit and QI, and therefore recognise that there's difference in terminologies. So how can we speak a common, a universal language so we all know what we mean when we're talking about engaging patients? It will be no surprise that I'm referencing the HQIP Developing a Patient and Public Involvement Panel for Quality Improvement document. That's there as a link, and these will be available for you. So we'll put the links in the chat at the end, and we'll tweet out about it afterwards. But it's about involving patients in the right way. It's about making sure that patients can describe their insight based on their experience and how they feel that care should be. And when we look at a direct quote from this document, involvement of patients and public in service development provides a different perspective from that of clinicians and from managers. And it's a helpful insight when we look at the subject viewpoint, because we look at clinical audit very, very differently. So delighted we have two of the HQIP service user network members here today. So the public represent patient's perspective, but it actually enables us to look from a different perspective. So we're doing a 360 on what we're trying to do, and enables health and care staff to make improvements on what patients feel are important to them as well. When we look at maximising the impact, it's really interesting when we look at the HQIP guide best practice in clinical audit 2020, which is still a very valid and important document. It says service and public involvement in clinical audit should be embedded in the organisation's public engagement strategy. The clinical audit programme should include patient-focused projects, and the roles played by service users and lay representatives should be acknowledged in clinical audit reports at all levels. And I'm just going to very carefully say, is that a gold standard? Is that something that we should be aspiring to? It certainly is something that we're saying is there and we should be working towards, but do we have that level of involvement? So we'll explore that just a little bit more. Some considerations. Somebody used in the Mentimeter, I wondered if they'd seen my slides before. It's not possible because only I've had my slides, but the question was, is patient engagement tokenistic? So how do we make sure we effectively have patient and public engagement in clinical audit? So it depends on our individual organisation. If we're in an acute sector, if we're commissioning, if we're participating in a national clinical audit. So it depends on the level of involvement in the clinical audit. And we do need to consider, so I'm pointing out some considerations. We do need to consider that it may not be appropriate to have patient and public involvement depending on the way that we are actually involved in a clinical audit. I'll leave that floating. We're going to come back to these as part of the panel discussion and exploring through. We should look at involving patients in the whole of the clinical audit cycle. So taking it from planning, if we're looking at co-production, we should be looking at patients and public, looking at what audit should we be doing. Thank you, Craig, for putting that in the chat. That's really appreciated. We should be looking at what is important to patients and taking forward so that we can actually engage properly with our patients at all levels of our clinical audit programme, but also within all stages of the clinical audit cycle. To do this effectively, we must each time look at our organisation, and we must look at what mechanisms we have in place. What are the experts? And that, for example, would be your organisation's patient engagement team, and whatever the name that team has. So quite often they look after the patient advice and liaison service. Link in with those experts because they are used to working with patients and the public as well, and that will strengthen and build with your strategy moving forward, and make sure you've got the buy-in of your organisation. We also need to think about ensuring that we have ongoing support for our patient and public representatives. So we are expecting our representatives to know about clinical audit. Are we providing training? Are we providing training in wording that actually allows them to understand? So removing the jargon, trying to have this universal language. Are we providing training with regards to the project we're asking them to support? So those with lived experience is another terminology that we might use. So those with longer term conditions, looking at multiple sclerosis. But if we've got someone that is a more generic representative, we may need to think about what is it we're doing with the project? What are we aiming to do? And involving them at all stages of the clinical audit cycle. We must make sure that our patient reps are supported appropriately. So we must make sure that we don't have a single patient representative coming into a meeting on their own to be siloed. That could be intimidating for any one of us coming into a meeting. It's about us supporting. So the project lead supporting and linking in with preparing the patient rep for the meeting, but also the debrief post the meeting. Are there any queries? Linking in with these key contacts. So as part of the panel discussion and moving forward in this Lunch and Learn, we'd love to hear more about what you do and how we can explore that and bring that to life. And I've got a couple of examples with what I'm doing with the Dorset Innovation Hub, where we're doing exactly what I've just described. And then on the final point on this slide is, are we focusing on the factors that matter to patients? And I've got an example here, just as an example. So 95% of patients with suspected stroke receive a CT scan within 24 hours. What about the quality for the other 5%? So quite often we will celebrate the fact that we've got 95%. We've achieved 95%. You know, if we have a cutoff level on our audit standard for risk at 80%, are we happy that the other 20% didn't receive that care? What if it means that ultimately it leads to death or long-term injuries, disabilities, etc.? Just need to think about that from that perspective, because we as clinical audit teams, as facilitators, as managers, as clinical directors, think very differently from patients and the public and from their perspective. So in my days as a head of clinical audit, one of the projects that I was doing was a research project called After Francis. And I did a big piece working with them. And actually, one of the patient representatives came up to me and said, "You're celebrating exactly the example that I'm giving there, but from the After Francis perspective." It was about near real-time patient feedback. "You're celebrating the fact that you've done quite well. You need to understand that my expectation is that 100% of patients receive that standard of care. That's what matters to me." And that's very humbling, and I would just like us to consider, to keep considering that as we have our discussions coming through. So different perspectives from different people in different roles, and obviously our focus is on patient and public. Further considerations, are we effectively engaging patients and the public in the whole clinical audit cycle? I've covered that a little bit, but it's thinking about planning. So are we doing the right projects in the right way? Are we actually asking our patient representatives, what clinical audits do they feel we should be doing? Are we looking at the right standards? So if there are a large number of standards and we always do these routine re-audits and re-audits, have we thought about actually looking at 4 or 5 standards where we actually are really not doing very well and focusing on those and trying to make those changes coming through? Have we actually got, have we considered patients' experience? So have we actually looked at their experience, looking at feedback that came up in Mentimeter just now, which is fantastic to see as well. So it's not just about the outcomes and their care, it's also about their experience. And again, another project that I was doing, again, it was a research project, I'm afraid, but it is important and it's very valid for this. We were asking about experience and the gentleman said, "My care's fine, not worried about my care, food's good. I just want my glasses clean so I can read my newspaper." And that was really powerful. So again, I'll just leave you thinking about that one. So delighted to be able to hand over to Kim and to the next stage of our discussion. Kim, let me know when you'd like me to take down the slides. Oh, you're on mute.
Sorry, yes. Yeah, please take that down the slide. I just want to make sure that we've got Adrian and Carol with us.
Yep, I'm still here.
Hi, Adrian. Hi. So I do have some slides which I'd be happy to present. Oh, hi, Carol, there you are. But we thought, after some discussion, Adrian, with Adrian and Carol, we thought, given that the decision that was made with this category, this award category, that we'd actually start with a discussion to hear what people, what their challenges might be, what barriers there are to engaging with patients and carers. I was delighted to see the responses in the Mentimeter because it seems like everyone actually has a clear idea of what effectively engaging patients and carers does mean. There was only one that I spotted that talked about struggling to engage patients. But everybody did seem to have a really good idea, but perhaps there's a barrier to taking the first step or the next step in actually making it happen. So I wondered, Craig, if there was anything that came up in the chat, or if there were any questions that anyone had, and perhaps we could start to look at ideas. And I can share some slides where I've got some different approaches that we could talk to. But maybe Adrian, Carol, would you like to introduce yourselves?
Okay, I'll start. I'm Adrian. I'm based up in Wigan. I've done some work with the local hospital. I was a member of the clinical audit team. There were 4 of us at the time. There were some issues then about us actually being able to look at any records because we weren't employed by the health authority, so therefore we weren't covered by their sort of confidentiality requirements, even though the 4 of us are fully aware of what that would require. So that sort of caused a bit of an issue about what we could get involved in. The other thing we were being asked to do was to help junior doctors, because they quite often have to do some research, but it was to help them interpret it from the patient's point of view and also give them some support in doing the analysis and things like that, because junior doctors, we all know, are absolutely worked off their socks. So to actually say you've got to do some research and write it up without any help was just another sort of, I think, impediment for them. So we were keen to do that, but I'm afraid, if I'm being brutally honest, it's fallen by the wayside. There were people who've mentioned already, you've got to be committed to it, you've got to resource it properly, and this really hasn't happened at all up here in Wigan. I've just come from a Health Watch meeting this morning. We do seem to have some new patient involvement people at the hospital, so I've left that one. I've come here. I'll be chasing them up later this afternoon to make sure they're going to deliver what they say. But they, for example, I've just seen Fisher Family Trust pop through here. The Fisher Family Trust is me in education. Sorry, the Family and Friends Test is what it is, isn't it? FFT. But again, who fills them in? Are they just the complainants filling them in, or are they just the positive ones? Are they anonymous? Are they not? How do you get that immediate feedback to enable you to actually do that improvement? Now, I've rambled on a bit, so I better let Carol get in here because I could be going for the next 20 minutes otherwise. So Carol, I'll pass over to you.
Thanks, Adrian. I'm sorry if I got background noise here. I'm actually at the Friends Meeting House in London because I'm on my way up to Liverpool for Confed. So, you know, one of those things that trying to split myself in umpteen pieces. I think my attitude about patient involvement is that you really can't do stuff without us. You can't get the full picture about anything without involving us. And I think that although it may be that some of you have had really bad experiences with patients who don't particularly want to engage, that they actually want to have a moan, that's unfortunately a common thing that happens. But I think if you actually get to know your patients and you get to know people, know them as people, you'll find that they've got ideas and comments to make that you haven't even thought of. And sometimes it's a very simple thing. I was working with the Beneficial Changes group, and they were talking about how to make a patient really comfortable when they're admitted to hospital. And I listened to lots of these really sort of highfalutin ideas, for want of a better way of putting it. And then I said, what about a cup of tea? And the answer to that was, yes, we're going to have a comfort break in a minute, Carol. And I said, no, talking about a cup of tea. Yeah, well, if you want to get yourself one now, you can go and get one. And I'm saying, no, shall I do it? And I'll say it really slowly. How to make a patient comfortable on admission is to offer them a cup of tea. Oh, we hadn't thought of that. Now, I know that sounds as though I'm being really sarcastic, and it's a very simple thing. You might think, yeah, a cup of tea, that's fine. Well, we automatically do that. But the thing is, you don't. And the thing is that it isn't thought of. And that's where we come up with some quite simple comments that actually could make a huge difference to a patient's experience. So I'm not going to rabbit on either. Otherwise, I could talk for England. So over to you guys. Oh, you want to know what I am? I'm a very outspoken person who works with the NHS Leadership Academy and with the NHS Beneficial Changes Network and with the co-production network. And if you want me to talk about kippers, I'm not very good, but if you want me to talk about co-production, I could go on forever. So there you go.
Yeah. Can I go back to one of your slides? You did show that slide showing that 95% of patients getting the CT scan might equate to good care. What happens to the other 5%? My question might be, so after they've had the CT scan, so you've ticked that box, what happened afterwards? What was the next step of the care pathway? Did it get delivered? How are you actually monitoring that? So it's important not to just have some of these sort of simple metrics which you tick and then give yourself a score if they don't actually follow right through. So it's actually about discharge, right? How are you getting through to the discharge? Is it actually on time? In a local hospital, we name no names, but I've just said where I'm from. We ended up with whiteboards above every bed saying expected date of discharge. When I was going round, I said to the patients, is that real? They said, no, they come around every day and just move on another day or so, So it's lost the whole purpose of it being there, which was to focus the attention of the occupational therapists and others on getting that patient ready to move on. So I think it's important that you get beyond just ticking the box to say that's what it was. And that's where I think some of these national clinical audits are a problem, because you're doing this sensibly to compare across the country, which is understandable. You can benchmark then to see how good your service is or not. But for your local patients, that may not be the crunch issue. It may be the timing of their appointments. It may be the fact that you're not actually prepared to open on Saturdays, which is more convenient for some of them to get up to hospital. All these sorts of things. I remember one patient saying to me, they want me to come at 9:30 in the morning. I've got to get out of bed. I've got to come 7 miles on a bus, and it costs me money at that time of the morning. If they gave me an appointment at 11, like I asked, I could come with my oldest pensioner's pass and get up at my own time. And the receptionist said, well, it doesn't cost you that much. It does. It costs time and effort. And if they had to come by taxi, it's 15 quid. Well, you know what that's like when you've got a pension. It's not affordable. So all the things that need improving aren't necessarily, like Carol says, difficult to do. Just requires attention from the receptionist to the consultant to the chief executive to actually knuckle down and get them done. That's the important thing. And I think once you start getting positive feedback from patients and a positive attitude from them, some of their other issues may just disappear as well.
No, very true that. And the other thing is, it's all very well ticking the box to say that you've done your scans to order, etc. But how long did it take for patients to get the results? And what I'm finding is that people are waiting so long to get the results of blood tests, of scans, of x-rays, whatever. And that waiting period creates so much angst for people if they've had a biopsy and they're worried silly that it might be cancer. And they're told, oh, we'll get the results, we'll send them to your GP or we'll get the results. And they wait and wait and wait. And in that time, etc. doesn't happen.
We're losing you a little bit, Carol. I wonder, really good points from both of you so far, but I'm wondering if we might be able to hear from some other people from the chat and see if there are any specific questions, because from looking at the Mentimeter, I think people did seem to understand why to involve patients. I'm not sure we need to be convincing people that they need to involve patients and carers. I think what we're looking for is maybe how. Is that right, Craig? Have you seen anything?
I think, yes, thanks, Kim. I've tried to do some kind of theming of what was said in the initial introductions. So clearly people want to know how they involve patients and carers. So we probably do all think that, yes, we agree we should include them, but people are unsure how we do that. Another point that I've picked out is people want to know, well, patients who are involved, what are we asking them to do? So it's all very well we're saying, yes, we need to include patients, but what are we actually asking them to do? So we need to understand, what demands on their time we're making as well from our side of it, so we know how to, deal with that. And then one of the other themes is there's a lot of people are interested in learning from others. So I think I have picked up there's a couple of people on here who have been managing to engage with patients in that way. And then also, once we've done it, how do we then maintain it? So how is it embedded as business as usual? How do we make sure that it's not just a one-off? How does it keep the momentum of what we set up? So I think you're right. There's been a couple of points. I don't know if Jordan's happy. I know it's Jordan Thompson, our Northeastern network rep, has mentioned that they've used 15 steps at their trust. I don't know if Vicky's backed that up. I don't know if he wants to come off and just explain how patients were involved in that. That's okay, Jordan.
Yeah, no, absolutely, that's fine. Yeah, so it was my previous organisation, Northumbria Healthcare Trust up in the northeast. We actually have the 15 Steps programme was a rolling programme, so it was actually built into the clinical audits team's functions. It was one of our key roles where we turned up unannounced onto wards and departments and carried out sort of mini CQC inspections, which were aligned to the CQC CAAW22. And we always did that with a matron from an area that they did not manage, so that it was as impartial as it could be. And as part of that inspection, not only was it visual in terms of environment and looking at medications, etc., we also interviewed staff and patients, and we always tried to do a minimum of 5 of each. And as part of the patient questions, it was everything from, you know, how did you manage to get parked? How did you find the reception staff when they greeted you, etc., all the way through to have you been involved throughout your care? Have you been told what your next steps are? Have they given you telephone numbers of who you need to contact, you know, if you have got questions? Everything right from the start to the end. And that feedback was given to the ward staff on the same day. So it was same day feedback. Not only did they receive a report afterwards, we fed back to the staff in the afternoon and to anyone else who wanted to come along on the same day. And I think the teams found it very useful and helpful. And I think that with the patients as well, a lot of them, I think I put in the chat, with some of them, it's the basic things, you know, a lot of them like personal care, being able to say that they've got the belongings with them, etc. You know, have they had food, have they had the water topped up, etc. And then communication as well. So the questions around, do they feel as though they're involved in the care, etc. You know, you say to them, do you know what medications you're taking? Have they been explained to you, etc. It's those sorts of things that I think they found really important to them. And
can I ask you a question,
yeah.
Jordan? Sorry, just to interrupt.
Yeah.
Who helped develop those questions that you asked for the patients? Was
so
it
the 15 Steps program, I believe, was actually an NHS program many years ago. And what happened was the trust, they sort of extrapolated the questions that were used as part of that, and they've aligned them to the CQC CAAW22, the key lines of inquiry, so that each of the questions fits into a domain, you know, safe, care and effective, well-led, etc. And the trust has a checklist that we obviously continuously update, but it's a standard sort of checklist that the organisation used that could be applied across the board. That's sort of what we did with it. And over the years, I think the trust really bought into it. So it actually became one of the key functions of the clinical audit team. You know, it's in the job description for the jobs in that team, etc. You know, you are going to be doing these.
so it's great that for this particular audit, you did actually get patient feedback. You asked patients and you acted on those and that feedback. But I think we can go a step further when it comes to engagement. And I think it's part of the team that sets the questions. It's part of the team that looks at all the responses. And then it's part of the team that can then champion that audit and moving forward and looking at how to make improvements, because you found that patients really were responsive. Could we go a step further? Because maybe we could be involving wider people and communities and not just specific patients that happen to be on the ward that day that were able to respond, that can speak English, that, you know, that were in a position to respond. And I think that's what we're really looking for when it comes to really working and engaging with people and communities. But that's great so far.
I think if you look at what the Royal Berkshire Hospital had a programme that started about 8 years ago, I think, where they put an advert in the local paper saying, if looking for people who've either been a patient at the hospital or a carer of a patient at the hospital to come in and join a panel to help us go forward. And so I volunteered for that because my mum had dementia, vascular dementia, and she was obviously a patient there. And what actually evolved from that was that it was various patients and various members of the public became members of the strategy groups, you know, the group for the elderly care ward, the group for the maternity. It was divided up into parents who looked at who got involved with the wards where their children would be, people who got involved with wards where their older relatives would be. And then they started a patient leadership program. So they basically grew their own network of patients that they could then call on for whatever was needed, for either clinical audits to actually, for example, when the King's Fund gave money for dementia wards, and the patient panel helped with the design of the ward, etc., etc. So I would strongly advocate that you have a look at actually growing your own network of people, because from the point of view of working with you on the clinical audit, that's great, but there is so much more that we can do to actually help across the whole health spectrum.
Carol, I think that's a really important point. What I'd like us to now do as part of the panel discussion is hand over to Craig, because I do think that there are large pieces of work out there, a lot going on in the organisation. So if it's okay, if we can hand to Craig for some questions, if that's all right.
Thank you, Sarah. One of the points I've picked up on, and I think this may be a common theme, is around time and staffing levels at the moment. So I'm just wondering if anyone's got any experience of how they've managed to, from an acute trust point of view, maybe how we've managed to actually set something up where we involve patients.
I think one of the first things, it'd be great to hear some examples, but one of the first things is to utilise what existing groups are already there within your organisation, going to your patient experience teams and other, maybe even your communications teams, because they might already have a network of people that they go to. But something that somebody already said on the Mentimeter results is about proactive engagement. So it is about getting out there, and you might find that your local health watch already has a forum of subscribers that you can actively use those groups to start your engagement process. Another thing that's worth considering is if you pick a topic, if you pick the audit and say, for example, it's diabetes, and then there's likely a diabetes group locally that you could access and work with to start that engagement process. But it'd be great to hear if there's other examples out there.
Anyone got anything to share around that? I know there was some comments in the chat. It's jumped on a little bit, but somebody suggested, or they've used volunteers, so their volunteer network within the trust.
Absolutely.
I just wonder if that person's happy to come off maybe and elaborate on their comment for us.
It'd be lovely if they could.
Well, I want to put something in, but Amanda.
It was you, Adrian. Sorry.
Yeah, so I do apologise for that. Essentially, you've got volunteers who are doing everything from meeting people at the front door of the hospital, taking them round the hospital to the right department. How do I get to X-ray? How do I get to a particular ward? Who's that nurse? All those sorts of things. And the questions they get asked en route about, it could be visiting times, it could be food, it could be anything. Those are all people who are quite willing and able, because they've got the skill set. They can actually relate to patients. They can relate to carers, because that's the important thing. You want someone who's got some empathy. Quite often, this is nothing against the staff. The staff are trying to deliver a service. You're in X-ray. You've got to be got through X-ray. They've got to make sure it's the right one, get it loaded up and sent back to the clinician as fast as possible. They don't always have the time to sit and talk to you and try and expand on answers. We did some work with the pediatric mental health section, and they said, can we talk to patients and their, well, obviously, and their mothers or fathers or whatever, and try and get them to expand on the answer. When you sat talking to someone, you say, how was the food? They say it was good. So we say, was the portions big enough? Well, could have been better, could have been worse. There's too much, the wrong time of day, all this sort of thing. And what you're going to get then is some actual quality feedback, which you can actually then do something about. And the point I make is quite often the things that patients want done aren't going to cost the earth. What they need is just a bit of common sense applying to it. I mean, one of the queries I've had when I was doing this Always audit was, why are all the bins in the hospital so noisy that in the middle of the night, when I drop a used item into the bin, it clangs shut and wakes up 6 people on that bed ward, And I said to the hospital, why can't you change them? Well, we will in the future, but at the moment it's too expensive. Well, it may be too expensive, but there must be some little rubber bungs you can put in somewhere just to stop a basic thing like that. And when you're in the hospital and you're there for a week or whatever it is these days, you're not always, but you start to think, oh God, someone's going to go to that bin again. Clonk, here it goes. And before you know it, you can get a fixation about trivia at the end of the day. it's important to change some of these things. And when I was in hospital, I had my hip done a couple of years ago. I was out of bed in 6 hours. Another surgeon wanted this patient to stay in bed, immobile, for 2 days. So, you know, if I was that other patient, I'd say, hang on, what's my surgeon done to me that's so different to what he did to you, that I've got to stay here for 2 days immobile, when everybody knows getting out of bed is the better, you know, keep you active, keep your muscle quality up, and all these sorts of things. So there are actually some simple things that patients can raise and people can sort out immediately, as opposed to thinking this is going to have to go up to the upper echelons and back down again. Can be sorted out on the wards. And I think you make use of the volunteers you've actually got now in the hospital. They'd be great to actually get on and find a really practical use for some of their activities as well.
So if there aren't any other comments, Craig, to highlight, I could share a couple of slides now.
Kim, do you mind if I
Yes.
come in? Sorry, I know I'm chairing this session, but there is an example. So I don't know if anyone's heard of the citizen panels, which are an NHS England initiative. There are 8 panels being trialled at the moment with the Picker Institute, and we are one of the 8 in Dorset. That is an amazing piece of work when you look at using the existing patient and public organisations out there, the charities, the different groups. So we look at Dorset Blind Association, etc. The list is huge, Community Action Network, and it's about pulling all those threads together. What we're talking about for clinical audit and how do we have a clinical audit programme is looking at something that is built into the culture of our organisations. So doing a smaller amount of projects involving patients that are done well, rather than being tokenistic. There was a question that is, I'll leave with Craig to pick up in a little bit, that suggested it could be a difficult question about how do you pick priorities, but we'll come back to that. It's about having a programme where you've got patient and public involvement that is supported and is an appropriate built-in sustainable part of your organisation. That's a massive cultural piece where we need to link in with the patient engagement teams. If we look at our clinical audit teams, depending on whether we're facilitating light touch, so touching base with doctors and they're doing their project, we're just checking what stage they're at, there could be 100, 200 projects on a facilitator's workload. Then we've got what we call at UHD, the more advanced level, where you're really doing the audit with the clinicians. They're more likely to be the projects we should have patient engagement with. And it's about it being owned by board. It's about it being supported so that we have it built in and we can feed up when there are difficulties, feeding in the points that Adrian and Carol have been talking about. So the example for Dorset, excuse me that it's me giving the example, I think is a very relevant one. And I think when we look at the other organisations across the patches, there will be other examples of that happening. It's about being able to say what we're doing, because it's not tokenistic if we're doing a certain number of projects. It's about actually making sure it's appropriate and we're safeguarding and supporting those patient representatives as well. So handing back to...
Sorry, I think that's an important point about the board buy-in and having, you know, the leaders, team leaders supporting that work, because you have to have that to take that forward. And that can start with thinking about, before you go out there and start doing engagement, you have to really think about some of the work that you need to do beforehand. And that is whether it's a proposal or a business case, or just kind of looking at, if you look at our strategy, we use the 4PI standards, which is 4 Ps are principles, process, presence, and I've got the other P, and the last one is impact. And it's worth looking at that as sort of aims to think about what exactly you're hoping for. What are your aims and objectives of doing this piece of work? And then once you have that kind of support, then you can actually start doing the activity. But I really think it's very important to have that set in your mind first and get that board buy-in. It really helps to put it down, put pen to paper first before you start the activity.
Absolutely. Thank you, Kim. Craig, handing back to you.
Thank you. Just going back into the chat. So it moves very fast, doesn't it? Let's have a look.
It's on fire, Craig.
It is. So we've got one comment around. So Stephen, one of our guests, was a PP chair, and it took over 18 months to set up a patient participation group. And I think the underlying message that Stephen's sharing is that it's not easy and it is hard work, and really you've got to be in it for the long haul. So don't expect anything you set up to happen overnight. It really is something that you've got to invest, I suppose, time, and you have to have that commitment in it, and it does require people. I don't know if Stephen wants to elaborate on that. He's more than welcome to.
Thank you, Craig. Yeah, hopefully people can hear me. I'm not so used to MS Teams, but yeah, I've been a PPG chairman for a couple of practices. I just think sometimes people don't understand how much effort's involved in this work. It was a really diverse practice, big practice in the city of Leicester. The PPG when I came to it was very, retired white, and it took a lot of effort to engage our sort of Eastern European community. We fair play to the staff. We were encouraging the staff when they were seeing patients in front of them to tell them about the PPG. When we had members or people in front of them could actually help with our membership. So picked up a couple of young mums, and there was a lady in a wheelchair, and we started to do really well, pushing out to people in the community, go into their places that they went to. So obviously some people's first language wasn't English, used some resources in terms of local media. And I think the thing that maybe I'd like to say to people is that I know we all want quick wins, but this isn't a quick win in terms of doing this. And I'd love to see the slides from Kim, because they keep being talked about, but I've not seen them, and I think it'd be really good to. I know Kim's worked at HQIP for a long time, and I'm sure she's probably got some really good stuff to share. But I think I appreciate people want quick wins, but it's not easy stuff to do. This is, and you've got to be in it for the long haul. You've got to be prepared. It took me 18 months, to get it anywhere near I was happy. And you don't chase perfection, because I don't think you're ever going to get a group, that's truly representative of your place of work, or where you are. I think the other thing I'd like to say is I think there's just this assumption sometimes that people can't contribute, and I think actually let's assume capability, irrespective of age and what's wrong with somebody. Let's actually assume that people can do this, this work, and that we can potentially get them involved, because I think again at times we don't do that, and we stop people, or we assume that they can't help us. And I think everyone's got something to say, especially in a world now where we can get everyone online.
Yeah, thanks very much, Stephen. How are you? I just think there's two paths to go down, really. And there is that one where you're talking about generalists, a group of people that want to be involved in a general way. And that's really hard. That's really hard to set up, and finding people that have that time, capacity, an ability to be involved in that general way. But we want to encourage people to be part of improving their services. And so where it's a bit easier and it's a quicker path to go down is if you look at a specific condition. And, you find those charities or those groups of people that, especially if it's a long-term condition and they're using a service all the time, then you're more likely to find people that want to volunteer to be part of that quality improvement, because obviously they use that service themselves. So there are those two pathways. But I think that PPGs, and we've heard of, there's quite a few patient panels around that support clinical audit in a general way. But yes, that's really difficult to maintain. But again, it's all about spending that time to set it up, spending the time to put it all down and get that group established to then maintain it. I think I will share some slides, if that's okay with you, Craig.
Absolutely. Can I just pick one point up before you do,
Sure.
Kim? I'm sorry. So Rob, who's just put something in the chat, I don't know if Rob's happy to come off and just elaborate. Maybe a slightly different approach to what we've already discussed.
Hi, good afternoon. Sorry, I don't have a camera on my PC at home. You're not missing much. So I'm a physio by training, and I've moved into academia recently and worked in a clinical lead setting in the Northeast, as you'll tell by the accent. And we're often trying to help people who are the term patience is used, but some people don't like that, and I get it. It comes with baggage. Patients or people without advocacy, I've heard. And so rather than closing the gate after the horse has bolted, is it worth trying to put some things in place by being proactive beforehand? So an example I'll draw on was when I was working as a primary care physio in the West End of Newcastle, which has got quite a large population of people from the Middle East, people who are of Islamic faith, would not be quite happy coming to see me as a male, which is understandable. I lived in Oman for a few years, so I kind of have a bit of an insight to the culture. And so people wouldn't actually become patients because they knew I was there. So we put in options for people. So we had another physio who was a female, but we also engaged with the local health centre that provided that was ran by people of their community to provide exercise classes to get people out and being more active, because that wasn't part of the culture of the people we were dealing with in that area. And so trying to maybe get ahead of the curve, as I said in the comment, that the largest predictors of health are socially determined, and we're only able to do so much in healthcare. It's up to the politicians really to help us out to stop people becoming patients in the first place.
Yes, I mean that point actually about language is really important, and the one that people should be using generally, and the one we're trying to advocate for, is people and communities, and that's coming down from NHS England. It's that new way of talking about engagement is to engage people and communities. I often talk about patients and carers because of the work that I specifically do, and it is patients and carers. But yes, I think locally, especially when you're trying to work with people, that's very true. And I like the way you said that point about maybe getting some proactive engagement first. I think that's a really good point about starting that conversation to get some ideas and hear from people to then inform your business case. Any other points, Craig?
No, that was the last one that I've picked up on. So I'll invite you to share your slides, Kim, if that's all right. Thanks.
Okay, so can you see them?
Yes, they're there now.
Okay. Right, so it's just the quick one to start with. This slide actually comes from some draft guidance, which is currently out for consultation, and it's an NHS England piece of guidance called Working in Partnership with People and Communities. So that's the thing I say about language. And so this is what a good organisation should look like. Listens and broadcasts less. It's focused on what matters to communities, including people from marginalised groups and those who experience the worst health outcomes. Develops plans and strategies that are fully informed by people and communities. Empowers communities to develop their own solutions to improving health for all. So I think this all creates a system where people have a greater say in how health and care services are run, and it enables communities to set the agenda for local change. So I think it's just a really important slide, and that's something to consider. And when you're talking about trying to get board support or senior management buy-in, this is actually what good organisations should look like, and they should be hearing from the communities that they serve. This is an image from that guidance, and I just really like it. It actually is exactly the same as Einstein's ladder, and all those kinds of different images that we've been using for decades. But it's talking about the different ways to work with people, different activities that you can use. So informing through letters and leaflets and online social media, animations, etc. Consulting can be through formal consultations to gather views. It could be webinars, meetings, and it can also be surveys. Engagement, so proper engagement is with focus groups and interviews using panels and forums and advisory groups, and also includes membership on decision-making committees and boards. Co-designing, so you can have co-design sessions with people with lived experience, so specifically working with not targeted group, but like groups of people who have experience in that care area, and they can be members on programme boards. Co-production, like Carol was talking about earlier, so that's asset mapping, appreciative inquiry and community conversations, partnership to reach a collective outcome. And it's really important to avoid being tokenistic. So that's tick box exercises, with unrealistic timescales and limiting the public dialogue. It actually should always be ongoing. Why involve? So we've talked about this before. I won't go through all of those. These are the areas that that we should consider why it's important to involve. That value for money, that's a really important point about it's a better use of NHS resources, because if you're improving health and outcomes and therefore reducing the need for additional care or treatment because needs weren't met the first time, you're making better use of the resources. Meeting legal duties. I wanted to add this slide and I think this is really important. That we've got all those very good reasons to involve people, but actually there are some legal duties, and failure to meet these risks legal challenge and substantial costs. And not to mention, it damages the relationships between organisations and the communities they serve. So it's just important to think about these different things. We have a duty to make arrangements to involve public in the decision making about NHS services. It's also a requirement on the NHS standard contract for providers. So this is the audit cycle. We've seen that a lot today. Oh, I should have a. So this is about looking at the audit cycle and what areas, how we can involve patients in each step. So number one is about looking at what's important to patients. With qualitative data, I have a little image that I put on top of there because I think it's a little bit more complicated when we think about data collection and data analysis these days with IG. But patients can be involved in leading discussions through interviews, shadowing patients and sharing observations. I think Adrian mentioned that as an example earlier. Or the clinical audit team can ensure they're hearing patients' views through focus groups, for example. 3, patients can be involved in taking the project forward. What are the recommendations that are most meaningful to their experience in their care? And they can be involved in the QI action plan, championing the project internally and externally. And 4, when it comes to sustaining the improvement, champions can be involved in promoting the project. They can speak to the board, speak at local events, and patient champions can help in spreading the word throughout the community. And that can really help by trying to engage people that are not usually so engaged, because they'll feel more comfortable to talk to other patients who've gone through the same similar stuff as them. And then we can hear from different communities, which can hopefully lead to learning and supporting marginalised groups as well. Oh, there it is. It's come up there. Okay, involvement in QI. So patient input into the service design is essential, as only they have experience as service users. So the involvement of patients in QI projects can take on different forms, and we look at patient representation at quality committees, shadowing the patient journey, patient-led assessments of the healthcare environment, completion of patient surveys, involving patients in reviewing information materials, especially the materials that are there, the resources that are there for the patients. Patient networking to share self-care strategies, analysis of patient complaints and concerns, and also involvement in quality focus groups. I don't know if any of you have heard of PENA, the Patient Experience Network National Awards, but I've been involved in that quite a few years, and I'm always seeing examples of how services have improved and show excellent engagement in preparing, testing, implementing small and then big changes to their services. So they talk about involving patients through focus groups and feeding back, and without this involvement, the changes just wouldn't be successful. So we talked, and thank you, Stephen, because that's a really good point that you made, but there are different ways to ensure that we hear the patient carer voice is heard through a project. So there is always the patient panel approach, which a panel that can work alongside a project, and they can serve as a kind of advisory group, or you can have representation on a steering group. But I do worry about that one, because you can't have one patient that just can possibly represent everyone. So I think this should be alongside other methods of engagement, such as focus groups. Active engagement with communities to involve them in the project. So that's, again, what I said about going to your local health watch or going to your local networks and charities. What else is already out there? Because charities have networks of service users, so you can work with them to engage and communicate and disseminate your work. these are the questions that you have to think about. Who do you need internally to support this work? So do you have a patient experience team, a comms team? What methods do the comms team already use to communicate to the public? It's worth speaking to HR about volunteer policies, the IG team around GDPR, also finance, refunding, you know, what resources do you have to cover certain expenses and costs? Ooh. This is the 4 PIs, so which one did I miss? Maybe process. These are the things to have in place. So it's really important to think about these things. Use these standards to develop a proposal which will help you understand the aims, resources and the benefits. And this can be taken to your management and board for support and approval. And to help in your thinking, I think it's really important to think about what do people and communities want from the audits? What do they want to learn from, and what do they want to be involved in? So it's also, as a patient, you want more knowledge about the quality of care that's available and to make informed choices about where to gain treatment. But it's a really good process to increase the public confidence in the NHS, especially in your local community. And it will help give the public a deeper understanding of some of the challenges that are there. And then once you've done that, patients can be part of the discussion when you're thinking about how to make improvements. So this is about where you can find people. So we've sort of gone through that, your surrounding area. What groups do you know that are established that might be open to hearing about this? You know, if it's a particular project around maternity, do you go to the maternity ward or local maternity voices partnerships? Falls, there might be elderly groups that you could go to, diabetes clinics, local health watch, faith-based centres. There was one story that I was involved in, some diabetes audit consultation, and I heard about this local group that used the diabetes audit data to help them campaign to stop the closing down of their local foot clinic. And just that's where your audits can really support communities and quality improvement. This is another image I took from that NHS England guidance that's out for consultations. But I think it really helps to make you think about what's in your community and where you can go to talk to people and ask for views or involvement. These, you can't see these very well, but this is on our website. These are resources that are there and they've been there for years. I've updated them a few times, but they are there. These are a couple of infographics. That first one on the left does tips to help consider how to present audit information to people and communities. But the one on the right is a useful checklist to use when thinking about engagement in your project or projects. We've also got an e-learning tool that can be used to support people who want to be involved in QI. We were talking earlier about the National Obesity Audit, and I've just set up a user panel to support this audit and for them to give their experience and to really feed in their experience to help influence how this audit is delivered. And what I've done is I've sent out this e-learning tool to just give them an idea about what quality improvement is and how patients and public can be part of that. If you are setting up a panel, you do need to think about policies such as volunteer and expenses policy. You might need to look at IG in terms of data security and just some of these things to think about. The guidance, Sarah referenced them earlier. These two guidance are still available. We haven't updated the actual guide since 2017, which has been a deliberate point because there's just so much resources out there. So now on those landing pages, we link to a lot of those new guidance that NHS England have done so much. There's lots of bite-sized information, NIHR, there's just lots of resources out there. So we're now linking to that. But this information here, it's still relevant and it does focus on clinical audit and quality improvement. I've got some local examples, but I don't think I'll go through them now. This is actually one that I really like because this is from the Falls and Fragility Fractures Audit Programme. And they had this slide shows that this was an aim for people with lived experience of using the fracture prevention service to be involved in the QI projects within their service. And they started with surveys twice a year. And from that, they developed a patient advisory group. And it wasn't defined, or it was more kind of ad hoc initially. but now they're moving towards representation in the clinical governance meetings more regularly, and giving the clinicians the perspectives about what matters to patients to guide the changes. The next few slides are a bit more about what HQIP do, and so I think I'll stop sharing now. Has that stopped?
It has,
Yeah.
yes.
I don't think I need to go into all the HQIP stuff and what we're doing, but I don't know, was that helpful, some of those different approaches?
From my selfishly, from my point of view, I think one of the things I picked up on, and this is something we talk about in our trust when we're delivering improvement training, is having a compelling story from around the results or around something that's happening to a patient. So I think it's easier for us to have that patient involvement, to give us that compelling story around how something's affecting a patient, then actually makes it easier for us to make those changes as well in our trusts. Kind of from that culture, we talk about culture being a really big part of change. So it's really resonated for me, and I think that would be one of the kind of tickets that would help us if we got more patient involvement. Then it would help us sell those changes to people.
And that's something that actually we're hoping to make this change. We've got a plan to make this change internally as well, because we have a lot of our commission programs. They do have some great patient resources, patient focused resources out there, and we want to support them in disseminating that, getting that out to people and communities, for them to use it in their own care, but also to help maybe influence local improvement. So a way of doing that is to actually have patients and carers talk about the recommendations and those standards that mean the most to them, and using that to support that dissemination. Yeah,
because for me, it's about making people understand why they're being asked to do what they're being asked to do. It's really key part.
I don't know, is Adrian still there?
He was a minute ago.
He was. He's
back in
dropped
again.
off.
Yeah, no,
Yeah,
he's back
here.
again. Yeah.
Did you have any further comments to add there, Adrian?
Well, I mean, my question really was, when we saw that Mentimeter at the beginning, there were lots of positive comments about why people should be involved, or patients and carers and everyone should get involved. So my query really is, if there's that enthusiasm and willingness to do it, what's the impediment to it actually taking place? This year we didn't manage to give this award out. Next year, hopefully, there'll be loads and loads of positive examples coming forward of where patients have been meaningfully involved from the outset in deciding how services can be improved, how they've actually improved, and then monitoring the change and actually agreeing that the change has been beneficial. That's what I'd like to think is going to come from all this. But it was such a positive Mentimeter thing at the beginning. I'm just surprised that more isn't happening. Or is it that we all know what we ought to be doing, but there's so many impediments in the background, management, finance, COVID, whatever it is, that it's actually stopping the implementation? Or is it because there's just not enough people, hence the need to get on and use some more volunteers in any capacity that you can actually drag them in? And because once we're in, we really enjoy doing the work because we can see a benefit at the end of it. But I think you just need to be brave and ask people, are you prepared to do it with us, and give them some training? It's not rocket science. And a lot of us old codgers, we do like going around talking, as you can tell. And we're the sort of people who patients might be able to relate to in a sort of very objective way. Objective. And talk us about their issues, as opposed to worrying when you're talking to matron or the nurse who's about to give you an enema. You don't really want to really get them too upset, do you, when they're going to do something like, or take a blood sample or something like that. So, make the most of it, make the most of us and all the experience you've got here, just waiting to help you.
I think I'm going to, pick up on, so Layla, thank you, Layla, for your comment. So she is probably speaking for most of us, Adrian, maybe, I don't know, but time and manpower is the impediment.
Yeah.
Potentially, which is what you've picked up. I've heard it said to me before that it gets put on the too hard pile because people, and I think that came, having dug a little bit deeper, that came from a lack of understanding of what's involved and what the levels of effort are that need to go into it. So I think maybe us having these discussions with people who are already involved actually break down some of those barriers. So for me, it's been a really useful education, I suppose, for want of a better way of putting it, as to the sort of things that you are asked to do and expected to do.
But as Layla's saying, there's too much other work to be done. But patient involvement, getting the patient involved from the outset, is actually key to the getting efficient cures, people back out the door quicker. So although it may seem you've got lots of other things to do, if the prime focus for health service is healthy people, like for schools it's educated children, then they've got to be the focal point, even if it is a bit of a finding the time to do it, because you can do so much. It's actually moving now, like with mental health and depression, moving away from giving people pills to giving them activities to do, to get together with other like-minded people. It costs less and it's actually more effective, but what it just requires some time to be put into it. And I agree, it takes.
And it's not prioritized, is it? It's not
No.
considered a priority, but actually it will make your projects better by engaging with people. So actually, if you put that little bit of effort and if you decide that it is a priority, then actually in the long run it will better serve your program.
It's almost like the treatment that we do at the minute is like a sticking plaster, and actually getting that initial engagement, I suppose, is actually dealing with the root cause, isn't it? So yeah.
But that's why I think start small then. If it is about manpower, start small, start with one project where you've got actually relatively easy access to already existing patient groups.
Thank you. I think those are really important points. I think we ought to start rounding up the discussion. Huge thank yous, Adrian, Carol, Kim and Craig, for facilitating so expertly, as I would expect nothing else. Really important points, wide-ranging points there. And when we look back on this discussion, I think just picking up on another point that Adrian made, I wonder, and I said at the beginning, we wonder as the panel, whether actually the name of the award meant that people didn't necessarily put forward for it. I think we could look at that, and it's important we look at that. When we look at the discussion that we've had, if I just round up this, and Craig, do add some additional points if you would like. PPI, we are in absolute agreement that there is enthusiasm, as Layla said, but the impediment is time and manpower. Picking up on Carl's point, patient involvement isn't optional now. We don't want it enforced by CQC. That's a really important point, but it's about capacity and how we do a small number of projects well, involving patient representatives, public representatives, patient and communities, in the right way, appropriately supporting them. So if we look at that, it is about an investment in time. It's about linking in with your patient engagement hub, as Vicky said in the chat earlier, or the teams, as I said earlier, to make sure it's legitimised. It's part of a programme and needs support. And one of the things that has also been raised is about friends and family, linking in with the experience, triangulating that information and that data through. I suppose when we look at how we can take this forward, we are taking it forward as a task finish group with NQICAN and working together with HQIP, so our members coming through, to look at how we can broaden the understanding of patient engagement and how we can do a small number of projects well. As Stephen said, it is for the long haul. These are programs that need to be established, and it is about change and culture. One of the cultures is that patient stories are very good, but sometimes it's a tokenistic patient story. How do we make sure that there are lessons learned and we take forward? So utilise the HQIP resources. And Kim, I'm glad you decided you would share your slides. I think everyone really appreciated that, and that was coming up in the chat as well. Utilise the HQIP resources. Be realistic, and in Adrian's words, not all audits need to have patient involvement. Really important. Build in that culture and actually make sure that we're starting with people. And that was the slide for me for today, was Kim's slide, was start with people right in the middle. I'm not going to put the slides back up. We're looking at one another, we're having a conversation, and I think that's what's really important. Our other slides are talking about clinical audit awareness webinars, so we will round off in a minute. Becca, if you could put the evaluation please in the chat, we would welcome feedback. It's really important, honest feedback, so please do the link. It's anonymous. Thanks, Becca, that's really appreciated. Tomorrow we have influencing change, so it's the lunch and learn for influencing change. So the amazing Vicky again sharing, Sam Riley coming through, and the amazing Layla as well, supporting, facilitating that. See Layla smiling at me. So huge thank yous. this I see as very much the start of the conversation. So we will bring this back, we'll bring back as part of the task finish group and take forward. Please spread the word about clinical audit Awareness Week. Please do join us for the other lunch and learns as you come through. And I'm particularly keen to listen to the 3 days. We've got health inequalities on Thursday as well, and future-proofing healthcare on Friday. So a great way to round up the week. Craig, do you want to add anything else?
The only thing that I was thinking is that we've talked about it now. I think we need to go back to our trusts and our teams and have a discussion as how we now take this forward. We can sit in a room or virtually and all discuss how we know we need to do it, and we're aware of that. But it's about the action now, isn't it, and what we do on the back of it. And hopefully this will just prompt that conversation and give us a way into, you know, we realise it's important, but how do we actually deliver on that? You know, it's easy for us to sit here and say, yeah, it's great, we can do it, but it's proofs in the pudding.
Yeah, it's that conversation.
End on a cliche. It's proofs in the pudding. So.
Proof is in the pudding. Go back to your organisations, as Craig suggested. Have a look at your clinical audit strategy. What is it saying we should be doing? Link in with your head of department. Work with them. Understand how you can do that in the organisation. Really valid point. So we're going to sign off with the hope that you'll complete the evaluation form. Huge thank yous to Adrian, to Carol, to Kim, to Craig, everyone that's participated in this conversation. Thank you so much.